Hi, everyone. My name is Yu Yang. I'm currently an assistant professor of medicine at Mount Sinai West in Morningside, where I am part of the gastroenterology department and the motility center at Mount Sinai. Today, I will be giving a talk on the management of constipation and fecal incontinence in older adults. I have no relevant disclosures. The objectives of our talk today are to discuss a systematic approach to the evaluation of patients with constipation and fecal incontinence, with special considerations for the older adult, and to also understand the basics of management for chronic idiopathic constipation and fecal incontinence. And this is really a focus on the basics. So why is this an important topic? Well, not surprising to anyone, GI conditions are incredibly common in older adults. For gastroenterologists such as myself, more than 40% of the patients that we see in our GI clinics are 60 years of age or older. And this is because GI functions are regulated by the enteric nervous system, which is intrinsic to the GI tract. It's also colloquially known as the second brain. And thus, there are many complex aging-associated degenerative changes which occur in the enteric nervous system, resulting in the increase of multiple GI conditions with aging. Constipation and fecal incontinence are two of the most common conditions that we see in our clinic. They are common in older adults. If you take a look at the graph below, this is from a very recent survey of over 6,000 individuals conducted in the US, UK, and Canada for some of the most common GI conditions. I will draw your attention to the gray and gold bar below, which focus on the two conditions of interest today, fecal incontinence and functional constipation. Interestingly, you see fecal incontinence is the only condition that actually does rise with age, whereas constipation almost has a more bimodal distribution. But both conditions are common in older adults, and it is important for geriatricians, primary care doctors, gastroenterologists to be familiar with how to manage these conditions in the older adult population. So we can't have a talk about the management of constipation fecal incontinence without a brief review of normal physiology. So normal colonic motility is consisted of both segmental contractions and propagated. Segmental contractions allow the formation of solid stools, whereas propagated contractions, which comprise of both low amplitude and high amplitude contractions, allow the movement of both fluid and stool contents throughout the colon. The high amplitude propagated contractions are the movements that are associated with defecation and occur about 6 per day and are most active when waking up and during meals. Once that stool is able to reach the rectum, defecation actually requires exquisite coordination of both the rectal, anal, and abdominal pelvic muscles. At resting tone, as shown in the image below, the continence is maintained by the external anal sphincter, which is under voluntary control, as well as the internal anal sphincter, which is under involuntary control. For normal defecation to happen, many things actually need to be coordinated. First, the rectum can distend to accommodate quite a bit of stool, as you may have encountered in your patients who have fecal impaction. But there must be sensory perception of the stool that has to happen as well. To adequate propulsive force for defecation to occur, a patient must contract their diaphragm, their abdomen, and their rectal muscles. They must also be able to relax the external anal sphincter, again, that is under voluntary control, and relax the puborectalis muscle, which is the sling that you see in the diagram here, to allow the relaxation of the rectal anal angle to allow appropriate defecation to occur. You can imagine how these sensory and coordination movements can be impacted by age, as well as the comorbidities that come with age, such as a history of pelvic trauma from childbirth, radiation, and previous surgeries. We have many tests at our disposal as gastroenterologists to evaluate for defecation symptoms, including constipation and fecal incontinence. And the two types of tests that we order include dynamic imaging with either barium or MRI defecography, where patients are asked to attempt defecation, and we assess for the coordination of the different muscle groups as we talked about earlier, and for other structural disorders, as well as anorectal manometry, which allows us to obtain objective pressure measurements to assess how the rectum and anal sphincters are working together during various maneuvers. I put down here, though, amongst all of these fancy tests that we have, a very good one that I hope that you will add to your repertoire is a rectal exam. So as a gastroenterologist, the rectal exam is a crucial part of my evaluation of defecation symptoms. And I would argue that it would be important to add this to your arsenal as well, as your ability to detect some of these abnormalities will improve with practice. So what are actually the components of a digital rectal exam? Because it's not just using your finger to just assess the rectum. First, it begins actually with inspection to assess if there are external masses or external hemorrhoids. We also assess sensation with the anal cutaneous reflex, where we stroke the skin around your anus in a centripetal fashion towards the anus. You can do this with the tip of your glove or a stick with a cotton bud. Lack of the sensation might indicate some neurologic deficits. Then there is the part where we digitally palpate for masses in the rectum, and we do ask the patients to perform various maneuvers while they are lying on their left side during the exam. We assess the resting tone. Sometimes you can detect a very low or very high resting tone that may be contributing to, either constipation or fecal incontinence. We ask the patient to squeeze like they're trying to hold in a bowel movement. Sometimes if a patient is unable to squeeze very well and they have fecal incontinence, this may be something that we can target treatments at. And then we ask the patients to push and bear down. And when we do this, I usually put one hand also on their abdomen to assess if they're actually able to contract their abdominal muscles to help to generate that propulsive force. We assess if that anal sphincter, as we talked about, is actually able to relax during defecation. With practice, you will be able to also feel if the puborectalis muscle, that sling muscle, is able to relax, and you'll be able to assess if the pelvic floor is excessively descending. Again, I think, part of this is coming with obviously a lot of repeat exams and expertise, but that I think beginning to incorporate this as part of the physical exam is important and can give you a hint of whether or not, for example, that additional physiologic testing may be necessary. So our agenda today will first begin with talking about the evaluation and diagnosis of constipation. When a patient is referred to me to clinic to talk about constipation, the first question I actually ask is, does the patient have constipation? So as a review, normal bowel movements for Americans include a frequency of between 3 bowel movements per week and 3 bowel movements per day. So this is actually quite a large range. The average consistency of bowel movements is between a Bristol 3, as you see on the chart on the right, to Bristol 5. The Rome 4 criteria, which is our GI criteria for defining functional constipation, includes 2 of the following, which is a combination of both symptom criteria as well as consistency criteria to help us suss out if this patient actually does have constipation. A clinical pearl is that I often ask patients what their most bothersome symptom is, because bloating is actually often associated with constipation and is their most prominent complaint. So it's important to figure out, even if they're constipated, what are they most bothered by so that we can attempt to address it. A stool journal can actually be helpful because studies have demonstrated that patients' recall of their stool frequency and consistency is relatively poor compared to tracking with a prospective journal. And oftentimes I advocate, as a clinical pearl, if your patient has abdominal imaging available, as many of our patients, end up getting a CT scan for one reason or another, there is a way to just scroll through, the images and look at the stool burden yourself. This is often something not commented on by the radiologist and just gives you an idea of how much, a patient has, because sometimes, even a large stool ball in the rectum is not commented on. There are many etiologies of constipation which can overlap and exist on a spectrum. On the right, you can see that there are these two buckets of slow transit and normal transit constipation. I will say that, differentiating between the two does not impact treatment, and that tests for colonic motility, even for a motility specialist, are rarely used. Other causes of constipation, which may be familiar in the geriatric world, include neurogenic causes and then medication-induced. Another big bucket that does not get as much focus are evacuation disorders. And these primarily focus on the defecation issues that was highlighted previously and include both anatomic causes, such as rectoceles, megarectum, intussusception, and dyssynergia, which we'll get into in a little bit. Dyssynergia is a common cause of constipation, which will not improve with laxatives alone. Dyssynergia refers to any discoordination between the abdominal, rectal, anal, and pelvic floor muscles during defecation. This can also happen because the rectum is less sensitive to stool that has, built up. And when these patients attempt to defecate, they are either unable to fully relax their anal sphincters, or they actually have a paradoxical increase in the sphincter pressures. Sometimes they have an inability to generate that propulsive force, either through their abdomen or through their rectum. And the important thing is that, these patients may not improve with first-line medications alone. Diagnosis is based on either manometry and imaging with defecography, as we discussed previously. And these patients, instead of just medications, would benefit from something called biofeedback, which is a specialized type of therapy where patients are working with usually a pelvic floor therapist or a nurse practitioner to retrain their muscles to generate either the appropriate propulsive force or learning how to relax their anal sphincter so that they can have appropriate defecation. And this is the gold standard with improvement in about 70 to 80% of the population. So biofeedback is going to be coming back to us in the fecal incontinence talk again. So it is an important component in our arsenal of treating defecation symptoms. Again, as we talked about, evacuation disorders can be evaluated on defecography and manometry. And I just put these images up here because not that you will be ordering them, but this is what, when you refer a patient to a gastroenterologist, what they will end up ordering and what they may see. And I think it is also important to consider, especially in the older adult population, mobility, sort of their comorbidities, whether or not they would be appropriate candidates for these additional testing, because there are many pitfalls which exist in these tests. They're not 100% sensitive or specific. And so the clinical picture must be considered prior to ordering these tests. So moving on to treatment of constipation with a focus initially on diet and lifestyle interventions, and then we'll move on to the pharmacologic options. Hot off the presses from last year, our two main GI societies actually combined together to put together the first algorithmic approach to chronic idiopathic constipation. And, it always begins with consideration if there are alarm features such as GI bleeding, evidence of rectal bleeding, either with hematochezia, bright red blood per rectum, or melena. If there are any evidence of anemia or weight loss, then, it is appropriate to refer these patients to a gastroenterologist for consideration of imaging and further endoscopic evaluation if it's appropriate for their clinical care. Now, I think, the consideration of what are alarm features changes with age. And in fact, I think most new onset of GI symptoms in the older adults are considered alarms. So GI referral is appropriate in most scenarios. Now, if this patient has been just having constipation for a long time, it usually alone is not considered alarm features without, evidence of bleeding, anemia, or weight loss. So the first step in these scenarios is to increase fiber. I put a clinical pearl here before we get into fiber, because if there is a large stool burden, as reflected in one of the earlier slides, what I like to do in these patients before even starting fiber or any medications is doing what I like to call a mini clean out, which is similar to doing a colonoscopy prep, but usually half the prep. And I use an example of a clogged shower drain, because I say, if you're just trying to pour down something like a Drano drop by drop, it probably won't do very much. And to sort of optimize any sort of the interventions that you want to try, whether it be fiber or other medications, if someone has a very large stool burden throughout their colon, it may be worth just cleaning them out a little bit first so that you can optimize the efficacy of any of the interventions that you want to try. So in terms of fiber, first, most Americans are not getting enough fiber in their diet, but assessing, what a patient's diet looks like might be helpful. Fiber theoretically increases the stool weight and reduces transit time, and may have a prebiotic effect, meaning that it might stimulate the growth or activity of intestinal bacteria that are believed to promote good gut health. In terms of what type of fiber is best, soluble, non-fermentable fiber is best. And this is also a clinical pearl. When you give advice to a patient to increase fiber, please give them something concrete that they can do, so they're not just going out and buying all types of different supplements. So psyllium husk is the one that has been the most touted as being efficacious. In this meta-analysis, so you do have to take psyllium supplementation at greater than 10 grams per day for at least 4 weeks for effects. I do tell my patients that psyllium and other fibers can increase flatulence. And it's also important to ensure adequate hydration with the use of fiber as well, to help it get its most effect, the best effect. In terms of dietary fiber, what has been really all the rage in the gastroenterology world are kiwis. This is one of multiple studies, actually, which have demonstrated that green kiwi fruit improves constipation, bloating, and abdominal pain. And it is something that is easy to add to the diet. Many of my patients prefer a natural alternative. In terms of other dietary fiber that has some evidence behind it, they include mango, ficus, and prunes. Other lifestyle therapies that have demonstrated to be helpful include the posture modifying device. This is known as the Squatty Potty. You may have seen the commercials around. One study demonstrated that in patients who had an abnormal balloon expulsion test as part of their anorectal manometry. Again, these were the tests that were ordered for patients with defecatory symptoms and constipation, that the use of a squatty potty, which allows for less straining and easier defecation, was able to normalize the balloon expulsion test in about 16% of patients. So that's about 1 in 6. I think in terms of costs, risks, and benefits, this is one of the easiest things to add to a recommendation for your patients with constipation and defecatory symptoms, especially those who report incomplete evacuation or straining. I've seen it anecdotally also to be incredibly beneficial. So just consider this, especially because it's, about $20 at any CVS. In terms of first-line medications, osmotic laxatives are our gold standard. The most common one that is used by gastroenterologists is Miralax or polyethylene glycol. It starts as 17 grams per day, and there's theoretically no limit, but I do find that patients, if they have to take it more than 3 times a day, tend to not adhere to that regimen as much, and it then gets a bit much. So I would say that, though, it is very efficacious and there are very few side effects or interactions with other medications with Miralax. So that is my first go-to. Lactulose is also part of the guidelines. However, the authors of the guidelines and, in clinical practice, it is an osmotic laxative that does cause more bloating and flatulence. So it is more limited in first-line use for constipation. Magnesium is also a great option and considered natural. I would say that, there are some caveats to using magnesium, especially in older adults. So those with renal disease and Parkinson's, we would avoid using the magnesium. In Parkinson's, magnesium in some studies has been shown to affect the absorption of Sinemet, which is why I do avoid it. Magnesium is great because it does come in both liquid and pill form. It is actually what I commonly use when I do the quote unquote mini prep in patients who have a large stool burden. And I want to just clean them out with, a bottle or 2 of magnesium citrate to get things started. The next next step in the approach to the chronic idiopathic constipation per the guidelines is to add stimulant laxatives. So these include bisacodyl, senna. Senna is a plant derivative. So when I do explain to patients, especially those who prefer more natural alternatives, I do try to sometimes talk about what are their theoretical benefits, as well as where it's coming from, because a lot of patients may be understandably hesitant to be on too many medications. Stimulant laxatives in general are very safe, and there has been some older myths about dependency, which have now been debunked. So senna and bisacodyl are theoretically safe to use in the long run. However, studies have not been demonstrated for long term, which is why some people are still sometimes hesitant to give it. But my first go-to usually is some combination of Miralax plus minus senna, because they have 2 different mechanisms of actions, and I find that it can have very synergistic effects. If there's one thing to take away from one of the things to take away from this talk for constipation is that please do not prescribe Colace. I do a lot of deprescribing of Docosate in my practice, but it is important to realize that there have been many RCTs which have shown that Colace is not better than placebo, especially because this is a TID medication. It's important to try to reduce pill burden and polypharmacy as much as possible in our patients. So do not prescribe Colace. You have many other agents that are safe, over the counter, that you can use instead. In terms of other therapies, and I do not expect any or all geriatricians to be comfortable in sort of prescribing secretagogues. These are a different class of medications compared to the osmotic laxatives and the stimulants. These are effective, and they do require prescription, so they are not over the counter. And how they generally act is to stimulate channels in the colonic mucosa to secrete water. In general, I will say that bang for your buck, these are not as good for the laxative effects. And many of these medications are not only dual proof for both chronic idiopathic constipation as well as IBS. I think it's completely reasonable if you feel that you've maxed out on, your first line over-the-counter osmotic laxatives and stimulants. If you don't feel comfortable prescribing one of these, to refer a patient to a gastroenterologist to discuss if one of these other agents may be appropriate. I just put the slide up there in case you would like to save it for reference and incorporate it into your own practice. All of these medications, minus the last one, Tananapur, again, are dual approved for chronic idiopathic constipation and have been around for a long time, and in general are very, very safe. And again, if these patients still have persistent symptoms, the authors of the guidelines also have put this consideration for the evaluation of pelvic floor or defecatory disorders really a little bit higher up in the algorithm than it has been previously. So if patients are still symptomatic, again, this is why we assess for the most bothersome symptom upfront. Despite the use of first-line pharmacologic agents, it is completely appropriate to refer them to a gastroenterologist to talk about whether or not one of these advanced anorectal physiologic testing is necessary. So now moving on to fecal incontinence. It is slightly a different beast to tackle than constipation because it is also multifactorial with different clinical subtypes. There is significant social stigma associated with fecal incontinence, and one survey found that 70% of patients don't report their symptoms to their healthcare providers. And again, fecal incontinence, if you recall from our initial slide, epidemiology-wise, is one of the conditions that actually does increase with age. In terms of common causes, 80% of patients will have more than one continence factor affected. These include the stool consistency. So anyone who has diarrhea or urgency may experience fecal incontinence. Stool burden and fecal impaction. Again, this is my call if a patient has available abdominal imaging to pull it up and scroll through to see if there is solid stool in their colon. I can't tell you the number of times where somebody comes to me with an issue of diarrhea or fecal incontinence, and I see that there is just a solid stool ball sitting in their rectum leading to overflow diarrhea. So that's especially really important before we initiate medications to slow things down. There may be anatomic issues as well with injury to the anal sphincter, either through previous surgeries or pelvic trauma from childbirth. Neurologic factors also play a role. Remember, again, in terms of what factors are important for continence, the ability to sense stool is important, but also to be able to act on that sensation, that sensory perception that there is stool in the rectum is important. So if there's impaired cognition, there may be more fecal incontinence because a person can't sense or cannot act on that sensation. Neuropathy can also lead to fecal incontinence through impacting the rectum's ability to accommodate stool and distend through both compliance and sensation. Again, in terms of fecal incontinence, sometimes it is useful to try to subtype the fecal incontinence based on the awareness of the desire to defecate before the leakage. Most oftentimes, though, physiologic testing may be needed, especially for some of the more invasive interventions that we'll be talking about on the next slide. So again, to summarize, various factors that can lead to incontinence, as shown on this diagram on the right, include a low resting or low squeeze sphincter pressure, This is something that can be detected on a rectal exam. There could be weakness of the puborectalis, that spleen muscle, neuropathy, which can affect both sensation and the ability for the rectum to distend and accommodate stool. This can lead to altered rectal or anal sensation. Diarrhea can lead to incontinence just because of the pure consistency of the stool, and diminished rectal capacity, as I mentioned. So the different clinical subtypes of fecal incontinence, and again, patients may overlap, include urge incontinence, which can be related to external anal sphincter dysfunction. So urge incontinence is usually these patients who describe they're really not able to postpone defecation, and they must, they can't hold it. They have to go immediately when they feel that there is stool in the rectum. Passive incontinence, or the loss of stool without the urge to defecate, is often attributed to internal anal sphincter dysfunction. Again, this is a sphincter that is under involuntary control and peripheral neuropathy. And fecal seepage, which can co-occur with any of the two above, it is can be related to incomplete evacuation and impaired rectal sensation. Now, moving on to the treatment of fecal incontinence. And this is the biggest takeaway, is that there is no consensus on what is the best treatment for fecal incontinence. As you summarize from the previous slides, there's so many different etiologic factors that can contribute to incontinence that it is sort of a personalized treatment decision between the provider and the patient about which one they would like to try first. I've listed here both the behavioral, dietary, and first-line medications for fecal incontinence, because this is usually what a patient will try first. And this is what I think would be helpful for geriatricians to have in their arsenal so that they can counsel these patients on these measures first before referring to a gastroenterologist to talk about perhaps more physiologic testing and more invasive interventions. In terms of behavioral interventions, these include timed toileting. This is especially helpful for those who have a component of overflow diarrhea. Dietary modifications can be extremely helpful. Avoidance of caffeine, lactose, and fructose has been shown to be somewhat beneficial. Fiber is this magical component, I say, that can help with both constipation and fecal incontinence, because it acts as sort of a sponge in certain scenarios as well to, help with the symptoms of fecal incontinence. And again, caution that with patients that fiber, while beneficial, can also worsen bloating. And before initiation of medications that are considered antidiarrheals, I put an underline again to really make sure that there is not a component of overflow diarrhea, because of course, initiating antidiarrheals in this scenario will worsen patient symptoms. I've listed a few different agents which can help either firm up the stool consistency or slow down the GI tract. Imodium is something that many patients reach for, but again, I do caution my patients that it can swing you to constipation very quickly. It does have fewer CNS side effects compared to Lomotil. So especially in the older adult, if this is something that they're very desperate to use, Imodium is a better agent than Lomotil. Cholestyramine or bile acid agents in general can be helpful in those who have pure liquid diarrhea to sort of improve the consistency. It doesn't improve the urgency as much, but studies has been shown to improve the stool consistency. Hyoscyamine, which is a gut anti-spasmodic. It can really help with those who have postprandial leakage or urgency symptoms. It's great because it can be taken before 30 minutes before meals to really prevent that urgency sensation that patients have. And Zofran is an agent all of us are familiar with for nausea, but actually does have benefits for both urgency and diarrhea. And again, all of these agents, one of their side effects is constipation. So would be very cautious to use these in patients who have overflow physiology. In terms of what is more in the toolbox of a gastroenterologist to treat for fecal incontinence, biofeedback, as we heard earlier, which can be also helpful for dyssynergic defecation in patients with constipation, can also be very helpful in patients with fecal incontinence. There have been many, many studies that have shown that, especially with a target treatment, it can help improve coordination and sensory training in patients. It may be helpful to do biofeedback after doing further anal rectal physiology testing with defecography or anal rectal manometry. Barrier devices are often used in many parts of the world with some benefit, especially those who have incontinence during social situations and want to go out, want something that is on demand. This can be very helpful as well. Other interventions that a patient can be referred to after they see a gastroenterologist include sacral nerve stimulation for neurogenic fecal incontinence. And then there are some sites around the country who are injecting bulking agents into the anal sphincter to provide that additional barrier. I will highlight that again in meta-analyses, many treatments did not significantly benefit patients compared to placebo, and that there was no treatment that ranked best or persistently improved outcomes, suggesting that there is just, again, there's incredible heterogeneity in the clinical symptoms of patients with fecal incontinence, as well as the different causes, which suggests that it really has to be a tailored, patient-driven treatment plan. So my take-home points for constipation and fecal incontinence management in the older adults. For constipation, if there are no alarm features, to increase dietary fiber in these patients and or with the use of over-the-counter laxatives and stimulants, including Miralax, Senna, magnesium, and using a squatty potty. You can consider escalating to the secretagogues, those prescription agents, or refer to a gastroenterologist. Do not prescribe colace, and to consider the evaluation of a defecatory disorder with either an MRI or anal rectal manometry if there is no improvement. But again, this can also be considered with a gastroenterology referral. For fecal incontinence, understanding that there are many different causes and no consensus on first-line treatment. It may be useful to differentiate clinically between urge and passive incontinence and fecal seepage, but oftentimes anorectal physiology testing with defecography or manometry may be needed. And there's a plethora of different types of treatments for fecal incontinence, including behavioral modifications, dietary modifications, antidiarrheals, but important to ensure that there is not a component of overflow diarrhea before doing that. Biofeedback, barrier devices, and sacral nerve modulation. Above all, I think counseling is incredibly important to patients. They like to have an escalation plan in place and understand that you guys are on the same page in terms of a treatment plan. And I thank you for your time.